Wow, thank you, Dr. Clark. This is a story that we're telling today. It's a long one, 25 years, preceded even in Dr. Clark's presence here at Primary Children's. We have nothing to disclose. We have a couple of objectives today. We hope to share this trailblazing history of standardizing bronchiolitis care at Primary Children's, and we'll be integrating lessons learned from science to shape a value framework for bronchiolitis care into the future. We have a lot of people to thank, and we wanted to start out with this. Up on this slide are all of the people who actually participated in contributing to this presentation alone. This doesn't even reflect the hundreds of people that have donated time to the bronchiolitis improvement effort over the years. The current improvement team is over 50 members, spans multiple facilities in the system. And so we can't possibly acknowledge all the people who participate in bronchiolitis care, but I'd really like to call out Brian Endicott from Pediatric Education Practice and Research, who helped us with all of the wonderful video that you're going to see today. We have over 25 minutes of it in here. Why bronchiolitis? This information comes from a survey we did of key leaders who have been involved in the bronchiolitis care process over the years. It's the most common admission diagnosis, the most common ED diagnosis. It's responsible for a seasonal surge that we just heard about and contributes to bed and staffing issues. There's variation in care, even in light of in part due to few proven effective therapies, and it's fraught with overuse. But we believe we do have an evidence-based care process, even if the evidence base doesn't tell us to do specific things. Supportive care is the norm for bronchiolitis. This is just a little bit of data. You can see from 1994 over the last 25 years, over 16,000 admissions to Primary Children's for bronchiolitis and RSV pneumonia. Everything else pales in comparison to this diagnosis in terms of volumes in our hospital. Value is the buzzword of the day. We've really probably had it drilled in many times. Value is quality over cost. As we shift from a fee-for-service environment into alternative payment, the only way we're really going to drive costs down is to improve quality. And what does quality care mean in bronchiolitis? According to the leaders we spoke to, their answers were really remarkably similar. We need to standardize and reduce variation. Standardization has to have some objective means of measurement. We need to reduce unnecessary care and rely on our evidence base. We need to provide care in the right place, at the right time, with the right length of stay.
So as we were interviewing people and the surveys that we got back, there were several themes that emerged, and one of the primary ones that I think everybody that we talked to mentioned was the idea that we can't do a whole lot clinically about bronchiolitis, and that the movement over the last 25 years plus for bronchiolitis is trying to not do things that are harmful, and this idea emerged of doing less is actually better. So the interviews that we did, they're videos, and the first one that we have on the video is Dave Sandweiss, who's here today. He's the medical director of the rapid treatment unit down by the ER. And then Mark Harrison, the Intermountain CEO. They're both in this video.
I think for bronchiolitis, clearly doing less is better, and there's a lot of evidence out there. So what we've done, I think, at primaries with bronchiolitis, I think follows what a lot of other places have come to realize, which is, we shouldn't be nebulizing these patients. We shouldn't be doing a lot of monitoring. We shouldn't be treating them with antibiotics. We shouldn't be doing chest x-rays. So I think that's kind of where I'm going with that. I think that is the case with a lot of medicine, quite frankly. Less tends to be more. I think we do a lot more than we have to for patients, not just with bronchiolitis, but with lots of things. So we go through pediatric residency and we take care of hundreds, if not thousands, of broncholytics. and we get to the point where we realize that nothing that we are doing is changing this illness, and that we watch these kids come in and just limp along for hours to a few days and then eventually just get better, regardless of what we do. So that is, I think, that feeling is kind of in the back of our brain all the time with bronchiolitis, that, oh my gosh, I hate this disease, nothing that I do helps.
Even at primary back then, the way I and we would generally take care of a kid who was admitted to the PICU with bronchiolitis seemed pretty brutal. You know, a kid would come in breathing hard, poorly oxygenated, and it would be boom, 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 get him tubed, get an art line in, get a central line in. And we got really good at getting these things done very quickly. But then you could just see everything would slow down for the kid. So, you know, maybe they don't get an NG tube in with feeding started until a day or two later, and you could just see how things would slow down. And I would always wonder to myself, boy, did we really need to do all that stuff to that patient, for that patient, that we actually did? And it struck me that the opportunity to standardize and base your response to the patient on their actual physiology, not on their diagnosis, and give them sort of the benefit of the doubt that less is sometimes more, was really appealing.
So one question you might have is, how did we rope Mark Harrison into being interviewed by us? Well, for people who don't know, Pediatrics is actually very well represented in the hierarchy of Intermountain Healthcare. And Mark is the CEO. But you may not know that he is actually a pediatrician, and he's also pediatric critical care trained. And he did his pediatric ICU fellowship and his pediatric residency here at Utah. This is a picture from the 1993 University of Utah Pediatric Residency Group. There are probably many notable people in this, but for our purposes today, there are two. So there's Mark Harrison there. And here's our old friend Chris Maloney with a little bit more hair. So Mark's interest, he also had an early interest in bronchiolitis. And this is a paper that he was the primary author on. It was published in Clinical Pediatrics in 2001. You might want to make note that this is the guidelines that they came up with, and there are 10, which will be somewhat of a theme for this later. Another theme that came up with us during the interviews is the importance of the outcome, and in particular, what outcome do we want to change? And the idea came back from just about everybody that we need to pick one metric and go with that. And for bronchiolitis, we know that we can't really change the disease process by itself, so how can we make it better for the patients? How can we at least make it less traumatic? And in the end, what are some of the things that we learned? In this next video, we have Doug Wolf and Tracy Hill, both of continuous improvement here at Primary Children's, talking about that theme. Oops.
One lesson that we learned and have incorporated into our approach to care process models and to process improvement projects in general is define what your target metric is. Don't just go in thinking, well, if we standardize everything, everything will improve. Go in saying, which metric is the metric that we really want to move, and all the other ones we want to make sure they don't get any worse. And that's really going to drive our decision making around the process itself. We decided, you know what, we were doing pretty well with bronchiolitis overall. We didn't have any big problems, but we really wanted to reduce length of stay. So if we started thinking about length of stay as the target metric. Reducing length of stay is our goal, and everything else is a balancing metric. We want to reduce length of stay without hurting any kids, without reducing the quality of care, without reducing the satisfaction of the parents, the kids, or the outpatient physicians.
So that started our basis in formulating this presentation around length of stay as the primary outcome. We didn't recognize that that was the primary outcome maybe at the very beginning of our journey, but we were able to retrospectively look at length of stay, and that's going to feed through the rest of the presentation and really ground us in our outcome analysis. So length of stay back 25 years was 87.1 hours on average. We started evaluating the bronchiolitis care process well before that, and you'll learn shortly why. We recognized there might be a problem. We recognized that there was a growing evidence base and that we weren't practicing in a standard fashion. Before even the first data was being collected on length of stay, we implemented a standardized order set in 1995, probably among the first standard orders created. And then in 1996, a really pivotal event occurred with a retreat. We don't think of retreats about diseases, but we actually had one in bronchiolitis. This is a video from Kim Benyon, who was a respiratory therapist at Primary Children's at the time. I really love this description that she provides of the retreat, but I want you to pay close attention to a really curious use of the pager that she describes.
I think it was sheer desperation that had the innovation, really. It was triple bunking patients on what was then the infant unit, and we just realized it wasn't sustainable. We literally had pagers where patients would, and their parents, would drive around the hospital waiting for their next time. It was run more like a fast food restaurant, trying to make sure we could take care of everyone. We said there had to be a better way. At that retreat, it was really the brainchild of a lot of people, respiratory therapy, physicians, nurses, child life specialists, financial folks, care managers. There were about 200, if I recall, a little over 200 people that went off site. The evidence had been about a 200 article review. I believe we used 80 of those articles to create what was then called the bronchiolitis protocol.
Rome wasn't built in a day, but it might have felt like that when they built the first care process after that retreat. It didn't take very long to realize that just saying it doesn't make it so. And they needed a champion like Kim who could shepherd a team along in this new process.
The QCAT team stood for Quality Care Assessment Team, and we thought it was our real first attempt at a real organized, formalized, interdisciplinary team. So it was comprised of respiratory therapists. In that first year, there was just 1.5 of us going out, and we would assess every child that was on the floors, ordered on respiratory therapy, and kind of create with the physicians and the residents a care plan for the patient that day. The team grew the next year to 2 more team members. We involved 3 more nurses from the different units and pods on infant unit and med-surg unit, and then we included the residents. And we begged for a medical director. We got one on year 3, and it was amazing.
Back to our run chart. So QCAT was created in 1997, but what we may not know, I think we think oxygen discharges are a fairly new phenomenon. We started them in 1997 with the first standard oxygen discharge criteria. The QCAT team went on to have some amazing outcomes. Obviously, look at that impressive reduction in length of stay through standardization. They created the first nursing clinical practice guidelines that became a standard for Intermountain in terms of how we disseminate best nursing practice. They used physician weekly reports on overutilization, which I dare say we maybe should start again. We have fallen by the wayside on that kind of level of intensive monitoring of the process. They did the first respiratory carnival, which we still do today, an annual skills day where nurses, respiratory therapists, and others come together to review the learnings from the prior season and educate each other. They started the process of evaluating the evidence and outcomes of the prior season and reporting them annually to multiple stakeholders so that we know how we're performing. We still do that today. They were responsible for the first dissemination efforts of the bronchiolitis care process, rolling out that clinical practice guideline to Dixie, Utah Valley, and McKay-D. This is an example, and I hope you take a moment afterwards to look at the sheer volume of abstracts that the QCAT team created, over 25 that we were able to get our hands on. But this one shows the outcomes related to that first dissemination of the clinical practice guideline at the 3 hospitals. We're going to highlight a couple of really early innovations. And the first one I'd like to highlight is the idea of the respiratory score. We really needed something to both objectively deliver care and the right care, but also to evaluate what we were doing. And our bronchiolitis score was first developed in 1993. There weren't validated bronchiolitis scores at that time, and in fact, very few still exist today. It was based off of a validated score from Woods and Downs that was developed in 1972 and modified over the years. But even more compelling than the introduction of a scoring tool early on in the care process was how it was used to minimize overuse. And I'd like to share with you Kim's.
The score was really used at baseline. We scored these patients, and this was in '97 when we started. We would do an intervention, for example, determine if they need to be suctioned. We would suction them with a nasopharyngeal catheter. Then we would leave the patients alone for 10 or 15 minutes, let them return to baseline, score them again, but that wasn't the only thing we did. We wanted to see if they could suck and swallow too. And if their respiratory rate was less than 60, we attempted that. If we felt like they were wheezing and it wasn't an upper airway wheeze because of inflammation but then we would determine they would get bronchiolitis, an albuterol treatment, give them albuterol treatment, give them about 15 minutes again to get back to baseline, and we'd score them again. If the score decreased by 1, it was defined as an improvement. What we found that very first season, with whatever score, rigorously validated or not, was that most of the patients just simply did not need the albuterol. They didn't respond.
More evidence of the evaluation. While they never rigorously evaluated the bronchiolitis score, there were efforts to demonstrate an association with increasing scores associated with length of stay, cost, and oxygen need. That was summarized in this poster.
So at one point we arrived at suctioning being a good intervention. It seems to be a relatively new intervention. When I was in residency, I don't remember doing a whole lot of it. Certainly not personally, but I don't remember the nursing staff or the respiratory therapists doing a whole lot of it. There are other therapies that have kind of come and gone for bronchiolitis. Ribavirin is one, steroids, other things. There's some question about where this concept of suctioning came up. Is it possible that it came up here in Utah? I'm not really sure. But we have Kim talking about that.
And somewhere at lunch one day, I said, I can't hear these kids' breath sounds. All I'm hearing is upper airway sonorous sounds, and I'm going to drop a catheter and see if I can clear out their sinuses, their airway, their upper airway, and maybe hear some better breath sounds. And it was like, voila, it was like a miracle. We had been throwing albuterol and mist tints and all this other stuff at them, and just in a small test of change, this little 2-person team, we would make sure babies could suck binky or nurse or take a bottle, and that was kind of the first thought that maybe there might be something in this whole suctioning idea.
One thing that impressed me in particular was the amount of work and the actual amount of evidence-based work I guess we're not supposed to use that word anymore, that phrase, evidence-based. But all the work that Kim was sort of in charge of, this is just highlighting several of those studies. But she gave us a list of all the abstracts and manuscripts that she had written, and it's quite extensive. So this is just, this is only half of the stuff that she was, most of it she was the primary author on. But there is one other person in here that we wanted to highlight today, who is a very good friend of Kim's and was very instrumental in all of these studies that were done, and also bronchiolitis care for quite a long time at Primary Children's, which is Julie Ballard, who unfortunately is no longer with us, but we wanted to highlight her contributions today. So unfortunately, she passed away in 2011, but here are several quotes from people that work here at Primary Children's who worked with her. She was doing a lot of good work, and she has been missed and will continue to be missed. Back to our story. This is a chart showing the utilization of the respiratory outpatient clinics, which was an innovation that we believe started at Dixie. So the blue on the bottom is Dixie Regional Medical Center in St. George. We are in sort of a grayish blue color. So the Rock Clinic was not started here, and it was actually somewhat of a late adoption. But the other thing that this illustrates is the increase in utilization of the Rock clinics. That's an idea that really has taken hold, and we feel like is one of the better innovations that came out of our bronchiolitis care during this whole time. So, given that the doctors don't really do much of the suctioning, if any of it at all, and there have been times in the past where I've been a little confused about, what kind of suctioning they're doing. One of our other interviewees talks about this a little bit later, but I just wanted to make sure that everybody knew what kind of devices we're talking about in order of increasing bodily invasiveness. So the first thing everybody knows is the bulb syringe, which is often thrown by the obstetrician in the delivery room at the baby on the warmer. But we also parents use a lot of it, and usually it's not terribly invasive. So the baby tolerance quotient, which is not a validated score, I just made it up, hurts a little bit. So the second modality is the baby booger grabber, of which I actually have one here today. It's not a big device. It gets hooked onto the suctioning on the wall. I'm not entirely sure that the phrase baby booger grabber is something that is universally used. It's a little bit hard to find references to that on the internet, but that is what we call it here. Given that the baby is generally lying on their back and they get saline squirted into their nose, they tend not to like it as much. So that gets the 4 hurts a little more. It is also made, this is a Frida device. I don't know if exactly this is the brand name Frida, but there are multiple suction devices such as this that are made for home use. And the child is probably not too happy about it as opposed to what is shown here. And so the second to last one we have is the deep suctioning, nasopharyngeal suctioning. This was just a still photo taken out of a longer video of the child's not enjoying it too much. It does help them afterwards, but they don't enjoy it at the time. There are also videos on the internet of waterboarding, which is not terribly different than what we do. Thankfully, they're better afterwards, but they don't tend to enjoy it. So that hurts a little more. And the last device, which we may adopt at Primary Children's in the near future, is the Arnold Schwarzenegger booger removal device, which he tolerates just fine, but babies probably not so much.
There are a few people who we weren't able to interview, and so I just did want to acknowledge their participation in helping us prepare. Carolyn Reynolds was one of those people. She's the long-standing operating director of the Pediatric Specialties Clinical Program, and she offered these comments on the innovations she was most proud of, including the initiation of the bronchiolitis score and the implementation of the respiratory outpatient clinics, in hoping to keep patients out of the inpatient setting. We're going to shift a little bit now to the next era of bronchiolitis care. There really was a paradigm shift that was occurring in the care of hospitalized patients beginning around 2003 when Dr. Maloney started the Division of Inpatient Medicine. He provides yet another example of the mark bronchiolitis really is made on future great leaders. And perhaps it is with some hindsight that he offered his motto of the wheels on the bus go round and round. At a time when community pediatricians were providing a majority of the general inpatient care at Primary Children's, you can imagine how difficult it would be to tackle reducing physician variation. And QCAT was successful in that by actually focusing on the residents at the front line and really driving home the care process through them. It's not hard to imagine Dr. Maloney surmising that a shift in care delivery to a small, consistent group of physicians might allow us to more tightly control the process and improve outcomes. And so Doug and Tracy again are going to talk about
So to give due credit, to my knowledge, the people who started the care process model for bronchiolitis at Primary Children's were a group of respiratory therapists before I had arrived. So this is going back maybe 20 years. Probably. And then, but then in its modern form, the interdisciplinary care process model was born out of an effort led by Dr. Chris Maloney after he had attended the Brent James ATP course, and he got together experts from each discipline, from respiratory therapy and nursing and physicians of different specialties, and they the method they used was to say, okay, we're going to define every aspect of care for a kid with bronchiolitis based on a consensus of expert opinion, because there is so little literature to tell you definitively how to do anything. How do you decide when to suction? How do you decide about feeding? How do you decide about admission criteria and discharge criteria? We didn't really have literature to give strong support for any of those decisions, so we were left with the consensus of expert opinion. And the idea was, if we, as a group, decide what's the best way to do every little thing and write that down and follow that carefully, good things will happen. Outcomes will improve. And by that, they meant every outcome. We'll have kids who are healthier, faster, we'll have shorter length of stay, we'll have lower costs. Everybody will be happier and healthier.
So sometimes consensus can lead to complexity. I don't think the idea here is for you to be able to read any of this other than just note its extensiveness and its complexity. Each different, there are 5 different sections of care, and children had to meet a lot of criteria before they were let to go home using these charts, which is what we used for a while. So the complexity really hit the nursing staff probably the hardest because it gave them a lot to do. And in the next video, we have Allison Kahutek, who is she's been a primary children's nurse for 20 years, worked on the infant unit for 17, and has had various leadership roles, including a time as the respiratory support nurse, or registered nurse. So here is Allison talking about her experience.
It was much more than just suctioning and applying oxygen, but then we started to think about all the different things that play into that, nutrition and the social end of it, and we created all these different algorithms for the nurses to go by. So there was a lot of education for the nurses, and it really made it quite complex of when you suction, when you do albuterol, if albuterol doesn't work, and suction again. And so the whole process to even assess and suction and care for a patient usually took about 30, 45 minutes for a nurse, and then all the other complexities. And when you're all done, you're back in the room doing it again.
So a lot of work for the nursing staff. So again, we had that complexity, and there were a lot of rules about when kids could be discharged. And it's just sort of an example of well-intentioned efforts gone a little bit awry. I mean, I don't think any of us really wanted kids to stay in the hospital for a long time, or longer than they had been staying, but unfortunately that is what happened. Doug, at one point, we didn't include this in the video, but Doug, I remember him saying that the care process models were more complicated than anybody could keep in their head. So on the next video, we have Allison talking about about what happened with the length of stay, and then Kim following that thought up.
Well, I think the biggest thing is that we just didn't think that families could go home with oxygen. That just was not even a thought, or suctioning at home, and we felt like every patient needed NP suctioning and every patient needed oxygen. And so they were here for the duration until they were off their oxygen and they had no more need for suctioning. And then on top of that, sometimes we wouldn't even feed them until days in, and they were on IV fluids, and then we had the issue of trying to get patients to start eating again. And so all that complexity, I think, made their days of 2 to 3 to 5 to 7 days for a typical broncholytic.
There became this urban legend, which is, I think it's just how things go sometimes, that you could not send a patient home if they had been deep suctioned, nasopharyngeal suctioned with a catheter. They had to be held discharged for 12 to 24 hours, which that was kind of ludicrous, because with really good documentation, if a patient had a 2 and the mom said, just drop the catheter one more time so I don't have to come back to the rock for 4 to 6 hours after you discharge me, we would drop the catheter and document maybe that the score was, a 2 and stayed a 2, but we had a small or a scant amount of secretions compared to what maybe earlier in that admit that patient had had. That should have been the indicator that the patient could go home.
So back to our run chart. This era, with Dr. Maloney at the helm, really capitalized on some of the things that he brought to bear, including his training in medical informatics. This is when Chameleon, or Patient Tracker, was born. And there was this idea that we could use electronic tools to help us improve both measurement of our process measures, but also compliance with the care process. You can see the unintended consequences here with the increase in length of stay attributed to that increase in complexity that we built into the process with all of those algorithms. This is just a screenshot from Chameleon or Patient Tracker where we used checkboxes to document progress toward meeting discharge criteria. But you can also see some of the complexity even of the discharge criteria alone. Do parents have transportation available? Are parents comfortable with all aspects of discharge? I'm not sure that ever happens in reality. Doug reflected on this time, and this is one of my favorite videos in the presentation.
I think one thing, probably the thing I'm most proud of with bronchiolitis is just the commitment to keep with it over the course of the years, despite discouraging results early on. And we went in, and Chris Maloney had formed that team, and the whole team was so enthusiastic and did what they had been taught to do and expected to get great results, and the results went the opposite way. And for a lot of organizations, I think they would have just disbanded the whole thing. We had failed. And they would have said, what's the point of continuing to meet when we only mess things up? But our people stuck with it and said, no, if we stay focused on this and we learn from our mistakes and we make modifications that are data driven, we will turn this thing around. So whenever people are discouraged about their process improvement projects, they haven't yet achieve the results that they meant to achieve. I always tell them the bronchiolitis story and tell them process improvement ain't for wimps. You got to be like the bronchiolitis team and hang in there if you want to get great results.
It's really important to highlight the role of continuous improvement in all of this, and I just want to highlight a couple of important quality improvement themes that emerged from multiple speakers. Here we have manage what you measure.
I also think providing data real time to the docs and the nurses was important. People want to know that it's working. I think we tend to remember the times when change doesn't work. And we go back to our N of 1. Well, there was a time when a patient was admitted on oxygen and they got sick and went to the ICU. And we remember those things. But it's really important to show people in a QI project real-time data and change. And that kind of reinforces the project. And that was helpful.
It's building that trust, and then also I think data is important. Maybe nurses don't really recognize until after the fact that with the evidence that really it is safe and it was okay, and personal experience is huge. And so then, speaking on the unit and telling nurses they are safe and they're going to be okay, and then coming back with the data saying they were safe is even better, so that then they could see that this was a good move for our patients.
Another one, the rapid cycle PDSA. Well, bronchiolitis, sadly, is not a rapid cycle.
Whenever we made, in that year from 97 to 2004, whenever we made a change, we made one change, not multiple changes. So we really could see, as with any good study, what variable was being altered, and if we saw the impact that we expected versus changing multiple things at one time.
And that was one thing that was kind of hard with bronchiolitis, is it's seasonal. So it was like these long PDSAs, a year long for each cycle, because you'd figure out what you were going to do your interventions, get all your data back, analyze it, so it was just, it took a long time to see how each thing affected. So yeah, 5 years, you're learning little pieces over 5 years or 10 years.
I learned that we couldn't really modify our care process model as soon as we saw that it wasn't going right, because there is so much work to get geared up for the season. So many people that have to agree so that we're all on the same page, updating educational materials, updating documents and forms so that they fit with the care process model. So it's not like you can go into 3 weeks into the season and say, uh-oh, something's not going right, let's just make some major change. You're on basically a cycle of significant changes only happen in between respiratory seasons. And having had that experience, I'm always very careful going into a process improvement project to be thinking about on what cycle are we going to be able to improve this, and we better make sure we're ready. If you only get a few chances, better make sure you capture all the information you need to do, jump right on top of reflecting and learning the lessons and getting ready for the next time you can try it, so you don't move a precious iteration where you could potentially improve.
I wanted to acknowledge Mike Mundorf, who has since retired. I think one of the motivations, there's the trailer that continuous improvement used to live in, and then they got to move into the beautiful Eccles building, and I think Mike missed his close quarters. He spends most of his time in retirement in his RV, so thank you so much to Mike.
So another thing that we hit upon during this whole process was this idea of keeping things simple, and we have this phrase called "keep it simple, stupid," which was self-admonition that was attributed to a gentleman named Kelly Johnson, who was the lead engineer for the Lockheed Skunk Works in the 1950s. And they developed and produced the U-2 spy plane and the SR-71 Blackbird. But it just sort of emphasizes that maybe simple diseases need simple solutions, and maybe the complexity that we came up with was not all that helpful. And here we have Tracy speaking, and then Mark Harrison again.
Here we have this simple thing that's like the most common diagnosis. You know, most kids do fine. A lot of kids don't even come in the hospital. And we've spent so much time, so many resources trying to fix and figure out, and, you know, how do we treat them? How do we get them out quicker? And why does it take so much to treat something so simple? And I think it's partly because we have that mentality of we need to fix. We have to do something. We can't just let the course run, you know, let it run its course. We have to try to do something. So I think we've made it more complicated than it ever needed to be. And because of that, we've had a lot of downstream effects and effort that maybe wasn't needed.
For a simple disease, the guidelines should be simple. Often for a complicated disease, the guidelines should still be pretty simple. And choosing which levers to pull, and you should only pull as few levers as possible to get the desired outcome, I think is the way to go. So I would imagine that I'm not surprised that when there was this like really great consensus-driven CPM that probably took everybody's feelings into account, it became so unworkable that the patients didn't get the care they needed.
So what was the end result of all this work that was done and all the experience and knowledge that we gained? This was in November 2007. You can see on the bottom, this was our what has become referred to as the one-pager, which is our care process model for bronchiolitis. It was initially intended to be sort of an addition or maybe a simplification to the flowcharts that were shown earlier. But since that time, the flowcharts have slowly made their way out of our process model, care process model, and we are left with this. The big champion of simplification from the physician side of things was our partner, Tiffany Glasgow. Well, some of the interviews that we did was a sampling of convenience and you know, timing, and unfortunately we didn't get around to interviewing Tiffany, but we wanted to acknowledge her contributions as well.
This next innovation's an old twist, a new twist on an old idea.
I think it was around 2006 that Denver published an article about utilizing an observation protocol for hypoxic bronchiolitis, came out in Pediatrics. And our group in the ER talked about whether or not we could try to replicate that in the observation unit in our RTU. We actually tried to do it. There's a very small pilot project where we admitted a larger than usual number of bronchiolitis to the RTU one winter. And that number was quite small because historically we did not admit bronchiolitis to the RTU because they stayed longer than our 24-hour kind of sweet spot. So we tried this, and utilizing kind of the Denver model, we found that it was very difficult to change culture and discharge patients home on oxygen, but we attempted to do it, and we knew there was data out there that said it was safe, but even then it was hard. So that was our first attempt at it. And then I think around the same time Tiffany was looking at it, and the hospital at large was looking at it, and then the ED and the RTU got pulled into that to try to formalize a protocol. OU HOT stands for Observation Unit Home Oxygen Therapy. And I'm not sure who came up with that, actually. It might have been me, it might have been Tiffany. It might have just fallen out of the sky, I don't know.
Here we are back to our run chart, and you can see the market impact that OU Hot had in the 2010-11 season when it was introduced. That coincided actually with the opening of Riverton, where we also deployed this observation unit philosophy on rapid discharges. This led to publication in JAMA Pediatrics, highlighting the amazing outcomes, including an estimated $840,000 in cost savings.
So one part of providing value is making sure that kids are getting the right care in the right place. Obviously a lot of that happened in our RTU. There were a lot of things that contributed, as we just saw, to the decreased length of stay. But here we have Dave talking again about the RTU.
So the rapid treatment unit it's basically a 23-hour observation unit. We admit patients there who we think are going to have a length of stay less than about 23 hours. And we're right about 90% of the time. And so on the front end, we kind of know when we're admitting patients there that they have a disease process that's going to resolve itself to the point that they can go home safely within that period of time. So that culture is there. That's kind of what the RTU does. That's our wheelhouse. And so if you can land in the RTU, you are going to go home for the most part in less than a day. The trick was getting patients, this population of patients, to land in the RTU. They didn't land there because there was this sense, well, the data showed that they stayed long. They stayed, I don't know what the average length of stay was prior, maybe 2 to 3 days. So they just didn't fall into our bucket. But once the home oxygen thing started to take on a life of its own with the Denver study, then I think we all felt these patients could come to us. And once they landed in the RTU, I think the natural progression was they went home quickly.
So we asked Dave where he thought most of the resistance to change was coming from. And as much as I'd like to think it wasn't so, it was from the physicians. But he and Ed talk a little bit more about how you inspire change in people in our next video.
I brought in lots of candy and lots of donuts and that first winter was rough. I mean, we worked really hard because we went from not admitting any bronchiolitis patients essentially to admitting, I don't know how many, a couple hundred.
What are the best incentives? I have found over the years that they're not financial, that they're incentives that are driven by expectation. And so we have, over the last 20 years, used board goals to incentivize people and also to incentivize the teams, and when those goals are reached, to allow us to celebrate.
Briefly speaking to the power of the board goal, we set a goal simultaneous with the OU HOT protocol to discharge more patients in less than 24 hours. And it really was that goal that drove the improvement and that driving down of the length of stay. We shot up to over 43% now on average of patients going home in less than 24 hours from our hospital. This comes with a few unintended consequences, including an increase in our readmission rate. There aren't national benchmarks that look at 7-day readmission rates for bronchiolitis. 30-day readmission rates exceed our current 7-day ones at about 6%. And this brings us really down to the tail end of our run chart here. We've had great sustainability with OU HOT, and we've shifted into an era of stewardship. Because I want to have time for a couple of questions, I'm gonna go towards the end. Our video took a little longer than I thought, and I want to share some final thoughts from Dr. Clark.
The leaders are often recognized, but equally so they may not be recognized. It's the teams that are not recognized, and we lose sight of it. And in fact, because of this success, people lose the history. And so I'm delighted that you're going back to review this, because the lessons learned from bronchiolitis are now being applied in so many other areas. And we want the next generation, our successors, to understand that it is a team coming together with a common purpose can make huge changes in our environment and in the way we treat patients.
I'm going to stop there and take any questions.
Questions? Is there anything we're not doing this year that we did last year? These patients?
Not doing. No, we made very few changes. Icentra really kind of causes you to take great pause. We don't really want to do anything differently this year than last. Icentra is the change. I'm expecting and predicting an increase in length of stay, just based on how I'm seeing the care process right now being implemented through Icentra. Hopefully we'll get really good at it really quickly when the surge comes.
Roles asking a question. So that was a great presentation. I remember before oxygen monitoring, taking care of bronchiolitis, and I saw alluded to that you switched from continuous to spot.
Spot check,
Yeah.
yep.
Why check at all? That's what's really influenced length of stay.
In many ways, it has. And in fact, we didn't get to share data from the emergency room when they switched to spot check and stopped using continuous, and our admission rates decreased. This is a tough one culturally to overcome. People are used to, especially at night, having the monitors there to rely on to know their patients are safe. And we've lacked an ability to actually audit our performance on this particular measure that I'm hoping we're going to gain now with Icentra, where we can become more aggressive in actually transitioning away from the monitoring.
We can't do an experiment to see, what level of hypoxia kids will tolerate for how long, and, what their developmental outcome and et cetera will be. I have always thought that people really like that objective information that a monitor ostensibly provides, but it's kind of gone in the wrong direction, and people have been relying on that too much. Allison actually spoke to that. We didn't include that video, but her efforts to try to get the nurses to rely on their assessment as opposed to what the monitors were saying. And I think we all know that the monitors don't work as well as we'd like them to. They default to low numbers, and the parents, for the most part, look at those low numbers and get concerned by them.
We should wrap up. It's 9 o'clock. Go forth and conquer bronchiolitis. We'll be seeing it in droves soon. Thank you.
I just want to thank both of them for a terrific journalistic approach and an innovative way of really drawing us all into Thank you.